Assalamu alaikum. This is a video about another left-sided nephrectomy for a non-functioning kidney secondary to PUJ stone. So I will also classify this pedicle as the difficult pedicle because there's a PUJ stone where I've been recurrent episodes of pyelonephritis leading to fibrosis and inflammation around the pedicle. Here I divided the gonadal vein so as to reach to the artery, but you saw that inferiorly one could see large lymph nodes, and these lymph nodes may be carrying the artery. I'm looking for it, and after pulling I see that there is a lumbar vein posterior to the artery, and this lumbar vein is extremely notorious, and if it gets avulsed or injured in the process of dissection, it's extremely difficult to control the bleeding from it. So this poses a lot of risk. I see some structure which is most probably a lymphatic, but I have to clip it because I think that the pedicle itself is really difficult, and we cannot take risk of bleeding or injuring anything else away from the pedicle, as well as we have to deal with the pedicle also. So I think this is lymphatic. However, there was a gross hydronephrosis, and there was a stone at the PUJ. There was an extrarenal pelvis. Some of the colleagues were suggesting that this was pelvis, but I was sure that this is not pelvis because the ureter was quite away, and ureter was going into the hilum, while this structure was not going into the hilum. However, I was thinking that this structure, being the lymph node, may be accompanying the renal artery. That's why I had to be really careful. I dissected it from all around, but there was a small structure attached, and I could not dissect and cut that area for the fear of having an artery. After looking here and there for the artery, I was convinced that there was no artery in that structure. So I started dissecting and mobilizing the upper pole just behind the adrenal gland. You can see the tip of the adrenal gland in my left hand. So I'm dissecting all the structures and the lymphatics behind the adrenal gland in order to find the artery and in order to find the pulsation. However, since this is a left-sided nephrectomy, the aorta is nearby and there are transmitted pulsations, so that can lead to misguiding of the surgeon. Here you can see that the vein is badly stuck all around to the lymphatics, which are then attached to the aorta. So you were lucky that we could dissect between the inflamed lymphatics and the renal vein. Once the renal vein was dissected away from the lymphatics, it was easy to dissect the superior aspect of the renal vein. So it was easy, but not that easy. It was really a tough tissue. You can see that my forceps is hardly making any impact on the tissue, and I cannot force it too much inside into the tissue in the fear that it may injure the artery. Here you can see that the artery has surfaced, and now we know that this is the artery and this is the inflamed and fibrotic periarterial lymphatic tissue. So we can use ligature to control this, and after that the principle is to to dissect the artery enough in order to apply a single clip so that the vein can then be dissected. It is always tempting here. Since the vein is right in front of the artery, one is tempted to apply a clip to the vein, but that will lead to severe engorgement. So we apply a single clip, albeit a little with difficulty. Now the vein is not distending, and we are using this right angle forceps. Always take 5 minutes extra to dissect the artery rather than saving 5 minutes and clipping and dividing the vein first, and then there is venous engorgement, and then you have to take another 50 minutes to deal with the situation. So always take 5 to 10 minutes extra to safely dissect the artery, apply one clip, and then clip the vein, divide it between the clips. As you can see here, it is divided, and now the artery is right in front of us. So we'll be applying more clips to the artery, and then after that we'll be dealing with the lymphatic tissue or the lymph nodes which were enlarged, and then the nephrectomy will be completed. Thank you very much for watching, and enjoy.